Georgina Bitsakou, thank you very much for joining us. So she is a consultant oncoplastic breast surgeon, meaning a breast surgeon who works with cancer and doing kind of plastic surgery. She's been working at Guy's and St Thomas's since 2019 and also representing their unit at the breast screening multidisciplinary team meetings and at King's College Hospital. She is the clinical governance lead for breast surgery. Previously, she had worked for acclaimed units in France and also in the UK. She is a doctor and a doctor and a miss, having a PhD in 2013, and her research then involved patients with breast cancer. And also, particularly, thank you for coming, she is on maternity leave with a newborn son. So that's wonderful of you to join us. Thank you. And I hope that, yes, I hope that your son is sleeping peacefully or similar. We'll also have Beverly Bowen, who is here, who is not going to give a presentation, but in the questions will be able to give a patient perspective. So thank you, Georgina, do go ahead.
Thank you for the introduction, Audrey, and congratulations on the initiative and on the excellent presentations. I will try to share my screen. So the topic we are going to discuss about is breast cancer. It is vast enough to discuss for many days, but I will try to focus on the most important, presumably, issues that have to do with this and with the women who are following us today. Breast cancer is the most common cancer in the women in the UK. Approximately 1 in 8 women will have breast cancer in their lifetime. And the most major risk for breast cancer is age. The older a woman is, the higher the risk to have breast cancer. There are some lifestyle advices that comes from the NICE Institute, and they have to do with achieving and maintaining a healthy weight, limiting the alcohol intake to below 5 units per week, and have regular physical activity. Having said that, there are women who follow every recommendation and they still get breast cancer, and women who don't follow for different reasons any recommendation and they don't get breast cancer. So as I keep on discussing with the women presenting in my clinic with breast cancer, no woman should feel guilty about having done or not having done something, because breast cancer can happen even in the best of effort to follow the advice. There are some genetics involved in breast cancer, but they have to do with only 5 to 10% of breast cancers, which can be attributed to hereditary reasons. The rest of the breast cancers are just random events. The family history, which is important, has to do with first, second, and third degree blood relatives of having breast cancer, but not necessarily ovarian cancer and some other cancers. And it's important, particularly when the relatives affected were having breast cancer at a young age, and when they're first degree relative to the woman who is asking for advice. The maternal and the paternal family history is equally important. It is a myth that the father side of the family is not as important. And the most prominent genes that are involved in breast cancer are BRCA1 and the BRCA2 genes. And we are talking about pathogenic mutations, meaning that the genes can have some abnormalities, but not all of them are related with higher risk for breast cancer. There are other genes which are getting checked when a genetic test is recommended, and this comes from the advice from the genetic clinic. The risk for hereditary breast cancer reduces with age. The older a woman is, the less likely her breast cancer is to be due to hereditary reasons. So if a woman who doesn't have breast cancer has a very strong family history of breast cancer, she can discuss with her GP and be referred to a family history genetic clinic for advice. We have the privilege at Guy's Hospital to have a cancer risk assessment service, which is accessible for self-referral to the residents of Lambeth, Southwark, Youself, and Bromley. So the patients, the women who are not patients, can refer themselves to the service and get advice as to how high their risk is for breast cancer. The risk groups for breast cancer are three. The population risk, because every woman is at risk for breast cancer, and even women with family history might fall in this group, meaning having relatives affected by breast cancer, but their risk not been raised. And then there is the moderate risk group and the high risk group. For women in the moderate and the high risk group, after the assessment, there is a screening offered earlier than the general female population and more frequent up to a certain age. So few women among the women who are in the high risk group are eligible to have a genetic test, and this is based on the genetic guidelines. This is a blood test to check certain genes and see if their risk for breast cancer is as high as to need some further different management. If the woman doesn't have breast cancer herself, then usually the affected member of her family needs to be tested first. There is counseling involved by the genetic team before and after the genetic test, and the counseling after the genetic test, if the genetic test shows pathogenic bad gene mutations increasing the future risk for breast cancer for the woman, involves discussion about further management, such as mastectomies, removal of the breast for risk reducing reasons, to minimize the risk for breast cancer in the future. The risk is never zero, even with the mastectomies, but it's much lower if the mastectomy takes place. I couldn't point out more the importance of breast awareness and self-examination. Every woman should get to know her breasts, because she would be the first one to feel any changes much sooner than any doctor. Having said that, there are many partners who are very helpful, and there are women who end up in the breast clinic with or without breast cancer because of changes that the partners have detected, and congratulations to them. So the sooner breast cancer is diagnosed, the better for its treatment and prognosis. We have to keep in mind that the two breasts are usually not identical. They don't look the same, they don't feel the same. And what a woman should pay attention to, and this is a very common question from the women who are attending the breast clinic, are changes in the same area of the same breast over time. We don't compare different areas of the same breast. We don't compare one breast with the other breast, because they're not the same. They don't feel the same. If a woman notices any persistent change, she should report this to her GP. And the breast self-examination should ideally be performed once per month, better when the breasts feel less tender and less lumpy, which for a woman who still has her menstrual cycle is around days 10 to 14 for a cycle of 28 days. A moment to discuss about how to perform the self-examination, which is, I think, very important. First, standing up with good light, ideally daylight, with no areas of shadow in front of a mirror, to check how the breasts look. First, staying still and then raising both hands and putting both hands against the hips and press to contract the pectoral muscle. In all positions, the woman should observe whether there are any skin or breast or nipple changes, such as skin dimpling, skin tethering, nipple retraction, skin retraction, visible lumps, diffuse redness of the breast. Then we lie on a firm surface, usually a bed, and we place the right hand behind the head, and with the inside of the fingers of the left hand, we feel the whole of the right breast and the area behind the nipple, which sometimes is forgotten, by performing cyclical movements, and we repeat the procedure for the left breast. We have to remember to touch the breast smoothly and not to put too much pressure, and not to pinch the breast within 2 fingers, because like this we create lumps which are not there. And at the end of the examination, every woman should remember to feel both armpits for any lumps. There are lumps in the armpits. They are called lymph nodes, and they're normal to be there. And especially for slim women, they're much more easier to be felt, and they are not a problem at all. But if a woman knows that she has lumps and those lumps suddenly increase in size, they become different, or if a woman has never felt any lump before and suddenly she feels a lump, it would be better to report this to her GP. So the symptoms and signs of breast cancer can be breast lumps, skin changes, as previously mentioned, dimpling, tethering, retraction, nipple changes, especially if they happen in one side only, because it's very rare to have breast cancer in both breasts at the same time. So nipple change such as the retraction or inversion when the nipple is flat or pulled inside the breast, nipple discharge, no milk discharge. And again, when it is in one side only, it can be more suspicious than when it is on both sides. Most of the nipple discharge means liquid coming off, running off the nipple. Most discharges are physiological, they are normal, but they need to be checked if they're new, especially if they come by themselves, not when a woman squeezes her breast. And we would advise every woman not to squeeze her nipple, because it has the same effect as when a baby is trying to breastfeed. It gives the message to the nipple, to the breast to produce. So please don't squeeze your nipples. But if you see liquid coming out for the first time and it continues, this should be checked. Nipple eczema is another symptom. New armpit lumps and diffuse redness of the breast when it is not related to a breast infection called mastitis, which usually happens during breastfeeding and improves on antibiotics. All those are possible symptoms of breast cancer, but most of the times, for a woman who is presented with those symptoms in the breast clinic, the outcome is not breast cancer. So no woman should panic when she has any of those symptoms before being checked. And an important point is that breast pain, which is a very common symptom, and every woman gets it at some period of her life or for different periods of time, can be hours, can be years, is not a symptom of breast cancer. It can coexist with breast cancer, be there at the same time, but it's not a way for breast cancer to demonstrate itself. So the woman with any of those new symptoms, new presentations, should ask for her GP's advice. The GP will examine the patient and they will refer the patient to the breast unit of their most local hospital if they're concerned, via the 2-week wait system, meaning that the woman should receive an appointment to be seen in the breast clinic within 2 weeks from the day of the referral. Most of the breast clinics in the major units, at least, are called one-stop breast clinics, meaning that the woman has a set of investigations at the same day. This involves history taken, clinical examination by a breast clinician, scans if needed, because sometimes they're not needed, and the scans involve mammograms and ultrasound scans, or one of the two, and biopsies again if needed, which are performed under local anesthesia. Some further scans and biopsies might be performed at a later appointment. Most of the patients coming with a symptom, with a problem to the breast clinic, will be reassured and discharged. Some of the patients will have the biopsies. The biopsies are going to be reviewed at the multidisciplinary team meeting called MDT and MDM. I'm saying that because we are using so many abbreviations. The women are getting the results and they don't necessarily understand what they are about. So we have a team which involves the participation of the breast surgeons, the breast radiologists, the breast histopathologists who see the biopsy results under the microscope, the breast care nurses, and we discuss all biopsies at that meeting, and we have a recommendation for further management. The patients who have biopsy results other than entirely normal, they will have an appointment to discuss the results and further management. All this was for the women who have a problem detected themselves on their breasts. but most of the women don't feel any changes on their breast, and still they might have breast cancer. This is why the National Breast Screening Program has been set up, and every woman in the UK between the ages of 50 and 70 are going to be invited automatically by the screening units by address to attend for screening mammograms every 3 years. Beyond the age of 70, the women can still get screening mammograms every 3 years until as long as they wish, until the end of their life, but it needs to be at their request. They need to phone the breast screening unit and ask for them. So if the mammogram results show that everything is fine, the women get a letter saying that the results are normal, and they get to repeat screening mammograms in 3 years' time. If the mammograms show anything that needs to be further investigated, the women will be called back for further scans and sometimes biopsies. The biopsy results will again be discussed in the multidisciplinarity meeting, and the women will get an appointment to discuss the biopsy results. Most of the times, those results are going to be benign, meaning good results not related to breast cancer. But sometimes breast cancer is going to be diagnosed, and in that case, further management will take place in the woman's local breast unit, which is not necessarily the same as the screening unit. Screening mammograms are obviously very important because they pick up cancers which cannot be palpated, usually, and therefore of smaller size, usually, and earlier stage, which means that the early detection can improve the survival, can give better chances for cure, and can reduce the treatment burden. It doesn't always happen, but the likelihood is there. What happens when a woman gets a breast cancer diagnosis? She has a consultation in the breast clinic with a breast surgeon, and the clinics are consultant-led, and a breast care nurse specialist. There are different types of breast cancer. I'm not going to get into details, but because we might have women who are getting their diagnosis now and they are interested in knowing more, there are generally two large groups. One is the pre-invasive group, the ductal carcinoma in situ, the non-spreading type of breast cancer, and the invasive group. And there are 3 grades in each group. The most common type of invasive cancer is the invasive ductal carcinoma, otherwise called of no special type, and then the lobular carcinoma. And we test every invasive cancer for different receptors, for estrogen, progesterone, and HER2, which are very important for the treatment options. Again, the recommendation for management and treatment is given by the multidisciplinary team. Further investigations might be needed, and in general, the breast cancers can be divided into early breast cancers, locally advanced breast cancers, and metastatic breast cancers, which are the breast cancers spread to other organs of the body. In general, there are 4 standard treatments for breast cancer: surgery, radiotherapy, chemotherapy, and endocrine treatment. But not every patient needs all 4 treatments. The type and the sequence of treatments is recommended again by the breast MDM and discussed with the patient, and they depend on the type of the breast cancer, the stage, the patient's general health, and the patient's preference. So the final treatment plan is decided together with the patient. We discuss the options, and the patients need to decide what suits better their life if there are more than one options given. And there is always the option not to do anything, which is not what we would recommend, but some patients prefer this way. The treatments are discussed in detail with the relevant team, the surgical or the oncology team, and there are other clinical teams such as physiotherapy, psychology, psychiatry, and plastic surgery, which might need to be involved in the care of a breast cancer patient. The surgery involves surgery for the breast because obviously we need to remove the cancer, and this could be a lumpectomy. Sometimes the patients need to have a marker, a special clip inside the tumor when we cannot feel the tumor, so that we know as surgeons which part of the breast to remove. There are complex lumpectomies. They are called oncoplastic procedures. When the tumor is a bit too large for the size of the breast, but we can still perform a lumpectomy. So we do some more complex things, more complex scars, and often they need an operation for the healthy breast so that it matches in shape and size with the breast cancer breast after we remove the breast cancer. And the third group of operations that we perform are mastectomies, meaning removal of the breast together with the breast cancer. And in that case, we perform this with or without breast reconstruction. I will have a special slide about this. The aim of the current modern surgery for breast cancer is to give the best oncological outcome, and this is the top one priority, meaning to make sure that the woman is safe from the cancer point of view, to remove the cancer, but together with the best possible cosmetic result, because the look of the breast, the image of the woman is very important for her quality of life. And some women mind this more than others, and we take this very seriously into account. And the surgery also involves the armpit, not always, but always for the invasive cancers. I'm not going to get into the details, and there are different types of operations that are performed for the armpit depending on whether there is tumor there or not, and whether the woman has chemotherapy to eliminate the tumor first. So the breast reconstruction is the creation of a new breast after a mastectomy, after the removal of a breast. It is offered to every eligible woman, and it can happen either at the same time with the mastectomy, with the removal of the breast. This is called immediate reconstruction, or at a later date. This is called delayed reconstruction. And there are different criteria, and also there is the woman's wish, which is very much involved in what she would prefer to have. There are some contraindications that have to do with a very high risk from having the reconstruction at the same time with the mastectomy. And these are smoking, or obesity, and high surgical or anesthetic risk for other reasons. The women who are active smokers and they're obese have a very high risk of complications from the reconstruction. It is not advised to have a reconstruction because it would increase very much the problems that they will have in the future. There are two main types of reconstruction. One is the implant reconstruction, where we put this prosthesis, this foreign body, which has to do with the silicone, and the flaps, which are woman's own tissue. And the plastic surgeons are involved in the flaps definitely, and sometimes with the implant reconstruction as well, depending on the setup of every unit. The other treatment which can be offered for breast cancer is chemotherapy. It's not always needed. It depends on the histology results and on the advice by the oncology team. It's a treatment with medication through the vein, and the patients discuss the details regarding the type, the duration, the side effects, and the possible outcomes with the oncology team. When breast cancer is positive for the HER2 receptor, it is combined with some blockade special medication, which works very well for this type of tumors. The chemotherapy can be given before surgery or after surgery. There are different indications for each pathway, and this again comes from the recommendation by the multidisciplinary team. Radiotherapy is local treatment to the breast and sometimes to the nodes around the breast, and it is routinely given after the lumpectomies. Sometimes it's even given after the mastectomies. And again, this is a treatment given under the care of the oncology team, which discusses the details and the length of treatment with the patient. And endocrine treatment is indicated for the cancers with positive estrogen receptors. It is usually the last treatment if a patient has the other treatments first, but sometimes it can be given before the operation for various reasons. And in few cases, in few patients who cannot have, usually because of their general health status or because of their wish, the other treatments, it could be the only treatment, although it would not be advisable for any patient who can have eradication of the breast cancer otherwise. There are different types of medication, and they mainly depend on the menopausal status of the woman. So what should a woman expect after she has treatment for breast cancer? The future, how well she's going to be, whether she will have a full recovery, depends mainly on the stage, on the histological type of the cancer, and there might be factors we are not aware of. But there are prognostic tools which can give to the woman an idea about what to expect for the future. Breast cancer is a treatable cancer, even when it is advanced, and in most cases, the treatments are given with the intent to cure the patient, and the outcome is good. After the patient has finished her treatment, she has a remote surveillance. In our unit and in most major breast units, we don't bring the patients back to the breast clinic routinely to examine them, because we know that we don't offer an advantage by doing that. Probably we increase their stress by having them waiting in the breast clinic. But they still get their mammograms as long as they still have one or two breasts. And for 5 years annually after the end of their treatments, or until they reach the screening age of 50, meaning if a woman has treatments for breast cancer before the age of 45, we're not going to discharge her before she enters the National Breast Screening Program. And what we advise to every woman is breast awareness, and the women have contact details. So the moment they find any abnormal findings, or if they have any stress or any question regarding their breast, they can phone us and we'll give them advice and we'll arrange to see them if necessary. Not to forget, although this is mainly about women and it is a very common cancer in women, that men can also have breast cancer, although extremely rarely compared to the women. And since most of us have fathers, sons, partners, siblings, we should remember to advise them to ask for advice by their GP if they find any lumps in their breast. So the take-home message, I would say that it should be that breast cancer is a common cancer in women. It is a treatable cancer with very good outcome in the majority of the cases. There are various treatments used in individualized combinations following recommendation of the breast multidisciplinary team and the discussion with the patient. Lifestyle changes, breast awareness, self-examination, and attendance for screening mammograms are strongly advised, and women with strong family history should consider referral to the GYN clinic for assessment. The earlier a breast cancer is detected, the better for the future. Thank you very much.
Thank you. That was a really helpful, that was great. I was thinking, gosh, if I was a medical student, I'd be thinking, yay, this is a fantastic. So thank you very, very much indeed. That was really, really helpful. Before we go on to questions, although if you do have questions for Georgina, do please put them in the chat. Beverly, do you want to comment at all?
I mean, my only comment would be that I've been through the experience quite recently, and it has been more or less exactly as you described, in that mine was actually picked up from my regular mammogram screening program. I went for that in 2020, and then I was called back and I had a biopsy, and I went to Guy's for my results, and the results unfortunately were positive. So I had breast cancer, and I was treated first of all with chemotherapy, which worked very well. And then I decided that I would have a mastectomy, followed by reconstruction. So I have to say I've been very happy with my treatment, and I really don't think I could have had better treatment, you know, even if I'd paid for it. It was just brilliant, quite honestly. The team are very good. They give you the chance to think about your options and to discuss them, either with the specialist nurses or your family or whoever. And they're very patient in that they will wait for you to make a decision. I found it very, very hard. So I made about 10 different decisions before I actually landed on the one that I eventually chose. But they were incredibly patient and very willing and happy to talk to you about the various options and talk you through them, which I found very, very helpful. At the moment, I'm on medication, and I'm also having some bone treatment over 3 years, twice a year, and that's essentially it. And I think I'm in remission. Well, I was given the all clear after the operation anyway, and you know, fingers crossed it will remain like that. So yeah, very grateful.
Brilliant. Thank you very, very much for sharing that, because that's, I think, quite a brave thing to do, share. So thank you very much indeed. That's really great. Question, what is the phone number to ring if ever needing advice, please? Yes. Is that, I'm not sure if this is for just a general advice or for family history. Is there a contact, or would you say contact your GP first and then they should contact you?
So regarding the family history, if a woman has a strong family history of breast cancer, she wants to go via the self-referral to the system, I can share the PDF with the information with you, Audrey, if that would be helpful, if you want to distribute it to the GP surgeries. Can't remember the phone number by heart, and I don't have access to the chat somehow. I don't know. It has been an IT disaster this evening, but I'm happy if to share the information, because there is a specific leaflet, and it is a very good service for the local population. They don't need to go via their GP, so it's a relief for the patients and for the GPs, because we know how overloaded the GPs have been. And the patient can get an answer regarding the assessment. If the question has to do with general symptoms, there is no way that they can get advice by phone, because they need to be examined. So they need to go via their GP first, and if their GP is concerned, then they're going to be referred to us, and we will go through everything. And for the women who had breast cancer, they have a phone number to contact. It's the phone number for the breast care nurse team, but they are given the number at the end of their treatment. So every woman who had breast cancer knows which number to call afterwards. I don't know if I have covered all bases.
Right. And I mean, I would say as a GP that, I mean, as said with Debbie, our first speaker, that yeah, I mean, if people come to us and we're not sure, then obviously if we're worried, we will refer, but quite often we will call somebody else or do an email. So yes, we are very often asking other people what to do. So there's a question, a general question about, will the presentation be shared? And the answer is yes, and people will get an email with a link to the shared presentation. I was really quite interested in, Georgina, what you were saying about advising alcohol being less than 5 units, because obviously most people would say less than 14. So that's quite, yeah, that's quite low, and I think quite low for a lot of people. So yes, I mean, is there, can I just ask, I mean, I'm not trying to say I want to drink more, but you know, is there strong evidence that that is much better than 10 or 14 or whatever?
It has entered the latest version of the NICE recommendations. And I think that most of the breast surgeons are not aware of this. I am personally quite reluctant to strongly mention that to the patients, because I don't want to create stress. It is a low number, And we know that alcohol intake increases the risk for breast cancer. But as I said, there are so many women who don't drink alcohol, they exercise regularly, they have very normal weight, they do everything correctly, as advised, and not that any other way is incorrect, but as advised, and they still get breast cancer. And they wonder, why did this happen to me? Because I have been, because it is a random event. It's bad luck in a way, breast cancer. Within the bad luck, the good luck is that it is a treatable cancer, and it is a treatable and curable cancer. And this is what I try to point out to my patients as well. It happened. Now we have to do how we're going to proceed. So I think, like every recommendation, which is not an absolute indication or contraindication, the alcohol intake has to do also with the quality of life and the preference of the woman. We recommend, if it's possible, in an easy way, without disturbing the life of the woman, that's fine. If it's not possible, I don't think that it's going to be traumatic not to remain those 5 units per week. But it is the official recommendation, nice recommendation. Not,
Lovely, thank you. I mean, I suppose for myself, I think, risk factors are risk factors, but they're often multi-factor, aren't there? There are lots of risk factors, and it's not just one or the other. And as you say, people get all sorts of things happen with no risk factors who, sort of look after themselves amazingly. Your point too about reconstruction surgery, if you are a smoker, you will not be eligible. How long, if somebody then stopped smoking, how long would they have to have been an ex-smoker before you would consider surgery?
We would advise ideally a minimum of 6 weeks. The longer they're away from smoking, the better. And there are different ways for a woman who wishes to have an immediate reconstruction, and she can achieve smoking cessation. If we're lucky enough to have a estrogen positive cancer, we can start her on the endocrine treatment first while waiting. So there are different ways. There are so many scenarios that it's impossible within this time frame to go through them, and they can be quite confusing as well. So we can achieve this if a woman can be positive that she can stop smoking entirely, and this includes every nicotine product. No patches, no e-cigarettes, nothing that has nicotine. It's not only the actual cigarette, it's everything that has nicotine inside.
Right. Okay, so it's the nicotine itself.
Yes.
Yes. Okay. Well, and that's sort of reassuring. I mean, I don't smoke, so I don't have to stop. And so I'm sure 6 weeks sounds huge, but at least it's only 6 weeks, which is maybe something that one could, contemplate. So that's really helpful. So there's another question in the chat. Does eating processed meats, particularly pork products, increase the risk of cancer?
For breast cancer, I'm not aware. I think, but it's not my expert field, that it increases the risk for colorectal cancer, different types of cancer, but there is no evidence that it increases the risk for breast cancer.
Right. Thank you. Yes. I mean, you say, there are risks, gut risks, and particularly, but thank you. That's really helpful. At the moment, there are no other questions in the box. Oh, yes, there is. That's good. I'm pleased. Thank you, everybody. Does breast reduction or enlargement increase your chance of breast cancer?
Not as far as we know.
Right. Okay. And breast implants, obviously there was the big scare about the leaking ones.
Well, if there is any rupture of the implant, this does not increase the risk for breast cancer, but it can be quite troublesome for the woman in different ways. So the presence of implants does not increase the risk for breast cancer. There is a particular type of very rare cancer, which is called anaplastic large cell lymphoma. It is extremely rare. It's about 1 in 24,000 to 34,000 women, so much more rare than the breast cancer, which arises from the capsule of the implant, any implant, the implant that is used for cosmetic reasons, the implant which is used for reconstruction. It's a very rare type of cancer, and it's not related to breast cancer. It's something entirely different. So the answer for the breast cancer is no, it's not related to the presence of implants.
Great, thank you. That's really very helpful. And I was going to ask you something, but now I was distracted by your cat, Beverly. I can't remember what I was going to say. It's very nice seeing your black cat.
It's not mine, it's Sandra's cat, I'm afraid. But he's desperate to be included.
Yeah. So actually, Georgina, obviously the first part of this evening was talking about HRT and, you know, the sort of potential risk with breast cancer. What do you as a breast surgeon or breast oncologist say to people about HRT, or do you have a, you know, an opinion?
We recommend for the patients who had breast cancer not to have HRT. I remember since my times in medical school until now, we have been having whole congresses regarding the HRT and the effect on breast cancer and different, and we can conclude there are different opinions. So I think that we should stick to the fact that everything in medicine is a matter of ratio, of balance between benefit and risk. And even though it seems that long-standing use of HRT might increase, not significantly, but might increase the risk of breast cancer, HRT is very much needed by some women because they suffer from very important menopausal symptoms. So everything is a discussion, and I think that Beverly had Deborah before covered very, very well the issue. So it's very difficult to answer by yes or no, but we definitely, and I think we all agree to that, recommend to a woman who had breast cancer not to have HRT.
Yeah.
And I would also include women who have high risk, they're in the high risk family history group for any reason for breast cancer, not to have HRT. For the women who don't have any additional risks and they need it, I think it would be very cruel to take the opportunity for them to have an improved quality of life by saying no to HRT.
Yeah.
Ideally, they should not use it for a very long period of time.
Yeah. Thank you. That's really helpful. Is breast size a factor for breast cancer?
Not the breast size, but if the breast size is due to increase to obesity, which sometimes is, but there are very slim women who have very large breasts. But we know that obesity is gives an increased risk for breast cancer. So the breast size per se is not. Again, if the breast size is related to very dense breast tissue, which is not always the case, because the breast has the glandular tissue and the fat. If we are talking about very dense breast tissue, there might be some increased risk. It's again a very, very extensive discussion that we should have, a matter of congresses between surgeons and radiologists, what would be other than the usual risk factors. So to summarize, if it is only the size without bringing in other risk factors related to the size, it's not at increased risk for breast cancer, the woman with larger breasts.
Brilliant. Thank you. And I'm conscious that it is dead on 8 o'clock, but I'm still going to ask you one more question, which is, does it matter where you apply HRT gel? Is it dangerous to apply it on your arms in case it has contact with your breast?
No, what would have any effect would be the amount of estrogen or progesterone which is absorbed by the body and circulates within the bloodstream, and it goes to the breast. So the proximity, the geographical proximity with the breast is not increasing the risk.
Brilliant. Thank you.